So this is Sam, PA to VC. I'm just waiting for
Okay,
sir to
okay.
begin the meeting.
No problem, no problem. We'll start at around 2:30 only, sir, sharp.
Right, sir.
Right. Praveen? Praveen?
Hi.
Praveen?
Yes, Praveen is here.
Ma'am, we will start running those prelude at around 2:30 only, madam, not 2 minutes earlier, because we have, we can finish fast also, madam.
Yeah, sure.
We'll start playing at around 2:30 only, madam, not before that, madam. Because we have only 10 participants. We'll have more people coming also now.
Okay.
Thank you.
There is not there, right? He's only.
This place is looking nice.
It is the same, no?
Correct. It's the same.
Only you're absent with your laptop in the background. Padmavati madam, I look like you only little. Dr. Kannan sir? Kannan sir? Hello? Hello, Dr. Kannan sir? Dr. Kannan sir?
Yeah, good afternoon, everybody. Hello.
Very good afternoon, sir.
Good afternoon. Do we have some time or are we starting?
So we'll just start in another 2 minutes, sir.
2 minutes?
Yes, sir. Please, sir.
Yeah. Can I request you if I can speak, second? Is it possible? I am attending one UGC chairman's address. Huh?
All right. Okay. Okay.
Yeah,
We can do that. Yes.
I'll join you say around 2:45, 2:50. Is that
All
right?
right.
Huh?
Okay,
Huh?
sir. Okay, sir.
Okay.
Okay.
Huh? Thank
Sure.
you.
Very good afternoon to one and all. And today is the day we are going to have the 21st webinar in this SBV Connect series on a very pertinent topic, which is palliative care. And we have our eminent speakers here today to speak on this much discussed but less implemented topic. So let's see how it goes. And warm welcome to one and all. I can see there are many more registrations coming in. If you people have any questions, to ask for the speakers, you may please put them in the chat box, and we'll be happy to touch base with you once the seminar is over. And we have the first speaker with us, our very own Professor Subhash Chandra Parija, our Honorable Vice Chancellor, Sri Balaji Vidyapith. Sir is an eminent academician, an erudite microbiologist, researcher, keen votary of medical education, and an able administrator. Dr. Parija has been the former director of JIPMER Pondicherry. He has been the author of 16 books and 400 plus research papers in national and international journals. Sir has been listed among the top 2% of scientists globally in the field of tropical medicine. FAO WHO expert member on foodborne parasitic diseases. Sir has received the Honorable B.C. Roy National Award MCI in the year 2003 for his nodal contributions to the development of medical microbiology. Sir is the founder of the Indian Academy of Tropical Parasitology, and Sir has been conferred with various fellowships that include FAMS, FICAI, FABM, FIMSA, etc. He is an astute mentor, my personal astute mentor. We welcome Professor Subhash Chandra Parija, our Honorable Vice Chancellor, Sri Balaji Vidyapith, Puducherry, to throw light on his topic. Over to Sir, please.
Good afternoon. Esteemed Lieutenant General Professor M.D. Venkatesh, Honorable Vice Chancellor, Manipal Academy of Higher Education, dear participants in this webinar on palliative care. At the outset, on my behalf of entire fraternity of Sri Balaji Vidyapith and our Chancellor, Sri M.K. Rajgopalan, I extend a hearty welcome to you all for today's interesting webinar on palliative care. I'm happy that the esteemed speaker, Professor Venkatesh, is here with us. We will be sharing his thought on concept of palliative care. Today, I'll be sharing my thoughts on another concept, another component of this palliative care, that is various challenges and way forward in integration of palliative care to undergraduate and postgraduate curriculum. I plan to present this talk. First, I'll briefly introduce about the concept of this component, particularly in medical curriculum. Then I proceed on deliverance on palliative care, and also I discuss the importance of integration of palliative care in medical curriculum. And why do we do to implement integration of palliative care in medical curriculum? What challenges health institutions face in integrating? And definitely, I'll conclude my talk the way forward with evaluation of this palliative care. As we know, need palliative care. Unfortunately, of this big number of persons who need palliative care, only less than 2% of them are receiving palliative care. It means majority of 98% of populations are not accessible to the palliative care, or they are not receiving any such care. Hence, those 90–80% of population who are not receiving proper palliative care are really in a miserable life, suffering from pain and other serious health-related sufferings. I just like to quote an interesting statement of Robert Louis Stevenson. It is not death I fear to face, but the process of dying that day. Thus, there is an importance of palliative care. Hence, palliative care should be integrated into all levels of care, including primary care with clear referral pathways, networking between palliative care specialist centers and generalists as far as possible in various settings, whether in a tertiary care hospital or a district care. What is palliative care? How we view it and how we interpret it. Palliative care is an integrated and holistic approach to the management of life-limiting or terminal illness through the prevention, assessment, and treatment of distressing symptoms. It's a new upcoming field of medicine that strives to encompass the whole patient and address their physical, psychosocial, emotional, and spiritual care. Most important component in a part of palliative care is providing clinical care with compassion. This is because of the rise in the acknowledgement and the presence of peace in clinical practice over the last 40 years. This has come out on a long way, and there is demand for more quality palliative care exposure and teaching, obviously in medical student educations, especially at the level of MBBS and postgraduate. The increasing demand and attention to palliative care education has also necessitated the creation of major opportunities for improving education about palliative care at the end of life. Hence, educational programs should be rigorously evaluated to identify best educational practices. There are many regions which can put forward for integrating component of palliative care in medical curriculum, of which some of the important components or regions are that more and more patients are being deprived of palliative care, hence are forced to go without any palliations because medical graduates and non-specialty doctors, they are not exposed or sensitized or trained in administering basic palliative care during their training at MBBS or postgraduate levels. Formal teaching of palliative care in undergraduate MBBS years is nearly non-existent. It falls into a no man's land and remains grossly neglected. It is not taught as a subject during MBBS. Therefore, a large number of undergraduates and postgraduate students have largely remained unaware of what palliative care means, and not understanding what palliative care contributes to the holistic healthcare, and even fewer have actually seen it practiced during their training program undergraduate levels. So the basic aim of integration of undergraduate and postgraduate curriculum is to provide undergraduate students an opportunity to explore and integrate palliative care with their clinical practice. This also aims to provide ample opportunities to develop personal and professional reflection about the management of patients with palliative care needs and devise the necessary strategies for integration. Importance of integrations cannot be understated. It is more important because palliative care learning should be initiated at the undergraduate level and postgraduate level. There's no rethinking of that. All healthcare professionals should have some components on education of palliative care. Hence, to this specific goal, there are various methods of incorporation of palliative care has been suggested. Some of them includes as practical training in hospital care, supported by practical and theoretical training, case presentations, workshops, and so on. In August 2019, the new CBME curriculum for MBBS students introduced by the Board of Governors of NMC fortunately has included an introduction to palliative medicines in the MBBS program. This is a big step forward. With the introduction of competency-based medical education by NMC and the attitude, ethics, and communication module at CONNEcT to these MBBS students, it reflects a welcome introduction to palliative medicines and obviously strengthen understanding the principles of palliative care. CBME is based both on vertically and horizontally integration of curriculum, and the palliative care competency framework has been thoughtfully woven into it under various subject specialties as well as within the outcome. The new undergraduate medical education program is designed with a goal to create a unique Indian medical graduate who should possess requisite knowledge, attitude, skills, responsiveness, and values so that he or she may function appropriately and effectively as a doctor, the first contact of the community while becoming relevant internationally or globally. Moreover, as a clinician, he or she is expected to understand and provide preventive, promotive, curative, and again I underscore palliative and holistic care with compassion. The clinicians is also expected to be competent in pain and distress alleviation and rehabilitation and palliation, so that the quality of the life will be improved and better for the patients who are suffering from these diseases. But though aim is novel and vast, there are many barriers for integration of palliative care in educations. I'd like to share that India ranks at the bottom of the quality of death index in overall score. There are too many barriers, too many obstacles, like population density, low socioeconomic conditions, geographical density, and for example, one restricted policy regarding opioid prescriptions, which are being given for pain alleviation, workforce development at this level, but also limited national PC policy and lack of interest at the institution level in palliative care. And more important being public as well as professionals in the field are unfortunately they're completely unaware, or they're very out of less information on this palliative care. Hence, this obstacles and barriers in the implementation of outcomes had aspects related to principles and practice of palliative care. So, lack of palliative care trained faculties in medical college who should teach the students the topics related to managing pain, symptoms of pain, sensitize the students the principles of palliative care, and inculcate the values of ethics and making decisions. End of life care and communication skill is most important, is not available. In the education domain, there is a lack of adequate education and training and perception of palliative care as end of life care. In the implementation domain, it has been characterized by inadequate size of palliative medicines, lack of proper trained workforce, challenge of identifying patients appropriate for palliative care referral, and need for culture change across settings. And obviously, a very poor policy domain due to fragmented healthcare system, need for greater funding for research, and lack of adequate reimbursement of the expenses that is made in palliative care and other regulatory barriers. So in essence, there are many challenges. Challenges for the medical college, students, as well as the administrators of the medical college. First and foremost being, there is a lack of regular outpatient services for pain and symptom management. There is a problems with an uninterrupted supply of oral morphine for intractable cancer pain management. Another component is difficulty to start consultative services in the whole of respective institute, medical college, for all those patients suffering from chronic debilitating conditions who need help. There are various issues. There are issues to establish a fully functional department of palliative medicines. There are many logistic issues are there. Hence, palliative medicine worldwide suffers from an identity crisis, as most healthcare professionals perceive is synonymous with the end of the life of the care, which is not true. Hence, with this state of affairs of palliative care and palliative medicines, we must move forward in different components. A set of learning objectives that are unique and unifying to be spread out throughout the curriculum and should influence other sets of learning. This can be in a linear fashion designed to add width and depth with each curriculum encounter spiral, where there is an explicit understanding of the expectation at its stage. The spirals may in turn contain uniting themes. Communication may be a spiral theme that initially covers basic skills in communications and clinical interactions. There is a need for integration within horizontal and vertical programming. So that can be achieved by adopting courses already existing within the curriculum, which can be further strengthened or adopted. For example, pharmacology courses can include essential medication for palliative care. There is a need for block delivery of specific courses. Palliative care can be delivered as a separate teaching course, either at one time point or in sequential sections in different parts of the course. For example, knowledge-based delivery via lectures of directed learning in the year 1 or 2, followed by 1 week clinical modeling, though placement in year 3rd or 4th year. There should be facilities for the student as one of the elective courses that can be used to support self-directed learning or focus on shared core competencies such as ethical judgment, professionalism, holistic assessment, and communications. For example, ethics special study model, where palliative care supports the learning of core ethical principles that contributes to developing ethical practice and judgment. And again, clinical placement within a palliative care settings where skills of patient assessment, communications, and multi-professional working can be developed alongside the management of advanced or chronic diseases that need palliative care. Just I like to share some of these activities we have carried out in MGM-CRI, the constituents of our university, Sigala Vidyapith. We have made a strong initiative by starting a hospital palliative care team that was formed in the 2016. In 1 year, we had more than 300 patient visits in our OPD, more than 45 referrals from departments like CCM, ICU, and so much. And we had more than 70 admissions. This, at MGM-CRI, we initiated a comprehensive and qualitative care due to participation of various specialties. And we had made a strong program for sensitizations on palliative care, on pain management and serious health-related suffering for this first year and second year MBBS students. And we did same 2 half-day sessions for interns in our MGM-CRI. And again, this HPC team members conducted several department-wise programs spread across seminars, symposiums on various issues and concerns of palliative care. We did some sensitization issues with the themes of even encourage the students as a compassionate care to take. We did 1 photograph contest. We had even to initiate and just give the people, make the students professional award, another design contest, and we did a continual CME program on the basics of palliative disabilities and so on. And we have been making a serious effort for successful integrations and efficacy of hospital palliative team made in delivery of palliative care to the terminally cancer patients. We want to support, take forward the importance, the relevance of palliative care to students, faculties, and public as well as. In medicines, we have integrated the palliative care by enumerating the common symptoms in patients with chronic illness and their implications on quality of life. In general surgery, we have an understanding about conditions other than cancer, which needs long-term care and plan appropriate management for the same for the students. In anesthesiology of many sessions, we ask candidates should learn different components, particularly to describe the drugs in the WHO analytic ladder and their effective usage. And also, we have been trying integrating palliative care in PG curriculum by the PG training component and importance for the surgical patient, the meaningful role of palliative care needs, and other components of palliative curriculum. The palliative care concept in the postgraduate curriculum programs like surgery offer engaging palliative care for academics to utilize while handling terminal patients. And a systematic review of palliative care intervention in surgical patients have shown that pre-operative decision-making interventions were associated with lower mortalities. And we wanted to evaluate on an individual basis, group basis, and by certificate reports about the importance of the evaluations, how far it's being effective for the betterment of the patient cares. And on this aspect, SBV, our university, holds two copyrights in PG curriculum. One, on integration of palliative care in undergraduate and PG nursing curriculum, SBV model. And we have also got a copyright on credit-based palliative care program for that student. We believe successful integration can bring definite changes, visible changes in the attitude of medical students towards palliative care and equip them with basic knowledge and skills. I must thank you for your patience hearing, and we are confident that palliative care is a need for integrations with this component of the curriculum of the undergraduate and postgraduate students to enhance the quality of the life of the people who need palliative care. Thank you. Thank you very much for your patience hearing.
Thank you very much, sir, and for throwing light on the topic. And I've been a member of the palliative care committee in the hospital, and we've seen it grow strength by strength over the years. And even during the pandemic, what we did was we had a list of clients who had admitted themselves in the palliative care unit of MGMCRI, and it was very difficult during the pandemic for them to acquire the necessary medications and nursing care also to their homes. So what we did was we called out each one of them, and we provided, of course, with proper precautions, the medications required as well as the nursing care required in their houses. So I've seen it grow in a very smooth and of course, it has not flourished as much as it should, but let's hope for the best. And we hope that our VC sir's recommendations and SBV's role model will be taken into consideration by the policymakers of the country. And let's move on to the next topic. We have here with us Lieutenant General Dr. M.D. Venkatesh Gupta, Honorable Vice Chancellor, Manipal Academy of Higher Education, Manipal. Professor Venkatesh Gupta graduated from Mysore Medical College in 1978 with an exceptional academic record and was commissioned in the Armed Force Corps in 1979. He acquired his MS ENT from Mumbai University in 1986 and is an outstanding ENT surgeon. He has contributed significantly in the field of medical education, having trained generations of undergraduate, postgraduate students in the AFMC Pune, and also having had the unique distinction of holding over the years all academic positions of AFMC from reader to dean. Sir was also a founder faculty of the Department of Medical Education Technology at AFMC. He was instrumental in instituting the online admission process for UG, PG, and postdoctoral admissions to the armed force training institutions that ensured total transparency and efficacies in the system. Dr. Venkatesh joined as Vice Chancellor of Sikkim Manipal University in 2017 and completed his 3-year term successfully on June 30, 2020. He has displayed inspiring leadership qualities and team building skills and has made Team SMU a confident, cohesive, and result-oriented unit. Under his leadership, SMU achieved the recognition as a leading private university in the country. So, ladies and gentlemen, I now hand over to Dr. Gupta, Honorable Vice Chancellor, Manipal Academy of Higher Education, to throw more light on the concepts of palliative care. So please.
Thank you. Thank you very much, Madam, for your generous introduction. And let me at the outset, thank Professor Parija for this wonderful idea of bringing in the concept of palliative care into public domain and ensure that there is a widespread discussion on this issue. And his presentation was really thought-provoking, and his thoughts about integrating the concept of palliative care in undergraduate, postgraduate, and also the initiatives taken by your university in taking things forward is highly appreciative. And let me, on my behalf, bring you greetings from Manipal Academy of Higher Education, an institution of eminence deemed to be university, to every one of you. And once again, thank the opportunity provided to share my thoughts with you all. I would be speaking on some introduction to palliative care. And the overview of my presentation would be, I would try to emphasize on what is palliative care, what is the worldwide palliative care need, challenges in palliative care provision in India, some of which Professor Parija has already highlighted, and the way forward as what we have done at MAHE, towards promoting and in capacity building and in provision of highest quality of palliative care to our dependent population. So this will showcase some of the important initiatives taken by MAHE in this regard. So as we all know, that palliative care is the active holistic care of individuals across all ages with serious health-related sufferings due to severe illness, especially of those near the end of life. It aims to improve the quality of life of patients and their families and their caregivers. This is as per the definition by IAHPC. What is important to realize is it is not a passive approach, but it's an active and holistic care that encompasses all domains of healthcare. The aim is also to improve serious health-related sufferings in people with severe illness and not restricted only to people with terminal illness or end-of-life care. Patients, their families, and caregivers are considered as a single unit, and the care continues to the family and caregivers beyond the death of the patient. And of course, the primary goal of palliative care provision is improvement of quality of life, having 4 broad dimensions, i.e., that is the physical, mental, social, and functional health. Some of the core principles of palliative care is prevention, early identification, comprehensive assessment, and management of all dimensions of quality of life, supporting the patients to live as fully as possible until their demise, applicable throughout the course of an illness and rationalized according to the patient's need. Palliative care can be provided simultaneously with the disease-modifying therapies. It is applicable in all chronic and life-limiting illnesses and in all healthcare settings. Often it is confused with end-of-care issues. However, it encompasses much broader scope. Palliative care facilitates positive influence on the course of the illness. This is very well understood. It intends neither to hasten nor postpone death, but it affirms life and recognizes dying as a natural process. It also envisages to support the family and the caregivers during the patient's illnesses and in their own bereavement. Palliative care is delivered recognizing and respecting the cultural values and beliefs of the patient and the family, and the care is provided by a multidisciplinary team of experts. What is the scope or breadth of palliative care services? The most important components of palliative care services include pain and symptom management, psychosocial support and family-centered care, creating quality health-related communication, in eliciting goals of care, shared decision-making, and advanced care planning. As I said, it can run parallel with the disease-modifying therapies. It is also important that we have a quality palliative care services which will help us in optimizing the health resource utilization, and also supportive care in managing comorbidities, complications, and concurrent illnesses also forms an important component of palliative care services. Other important component, especially when we know that the end is near, the terminal stage is there, end of life, management needs to be looked at. It is also imperative that there is a careful discharge planning and the continuity of care in the community. This is equally important. I come to it a bit later. Integration with all disease-directed therapy, both in curative and non-curative settings. I think this is very important, as I emphasized in the early part of my talk, that the scope of palliative care services can run parallel with both curative and non-curative setting in disease-directed therapies with regard to the disease conditions. And more importantly, as most of us understand, palliative care also includes end-of-life care and bereavement support to the family and the caregivers once the terminal event has occurred. So if you look at it now, you have the entire range and breadth of the palliative care services one need to concentrate on. It's not about just pain or symptom management. It's not about end-of-life support or providing the home care to those patients who are terminally ill. What is the global palliative care need in adults? Contrary to common belief that the cancers constitute a very large component of palliative care need, if you look at this chart, you'll realize that cancers constitute less than 30% of the total need of palliative care across the world. And literally, if you look at the list of conditions and the organs that are involved in patients who require palliative care, predominantly it is the malignant neoplasms constituting around 28.2%. We have HIV and its complications, which has about 22% of the need for palliative care. Then the other conditions, major conditions include dementia, degenerative central nervous system diseases. Then we have non-ischemic heart diseases. About 5% of the patients with chronic lung diseases will require palliative care. Otherwise, the list is literally encompasses all organ systems and all systems of the body. And once again, emphasizing that malignant diseases, patients with malignant diseases who need palliative care constitute less than 30% of the total need of palliative care across the world. The picture for the pediatric age group is quite different. When you look at it, predominantly children who require palliative care, it is HIV and related complications, close to 30%. We have 17% premature birth and birth trauma patients. Then we have congenital malformations, which account for close to 16%. Another 16% in the pediatric age group require palliative care due to injury, poisoning, and other external causes. Therefore, here, curious to notice that the malignant diseases constitute less than 6% of the need for palliative care in children. Again, the scope of palliative care involving advanced diseases literally covers all the organ systems of the body. When we look at the age-wise palliative care need distribution, this is again out of 2020 Global Atlas of Palliative Care. you can see that the palliative care is needed for all age groups. Though predominantly more than 68% of the patients above the age of 50 years constitute a large group, but significant number of adults between the age group of 20 to 49 require palliative care, and children between 0 and 19 years of age constitute 7% of the total patients who require palliative care across the world. So therefore, its palliative care is needed across all age groups, but the concentration is predominantly in the elderly age group beyond the age of 50, and more so in adults beyond the age of 70 years. Physical symptoms that need palliative care. Again, you look at pain, both mild pain and pain, moderate to severe pain constitute around 20% of the need for palliative care. Dyspnea around 6.6% or 7%. But more importantly, it is weakness and fatigue, which constitute close to 40% of the patients who require support because of these symptoms. The other prominent symptoms which need to be supported include dry mouth, constipation, nausea and vomiting, confusion, delirium, anxiety, and worry. Again, significantly, we must realize that palliative care is not limited to pain management. There are diverse symptoms that need to be addressed to when we are looking at a comprehensive palliative care for, terminally ill patients or end of life support that is required. And who are these people belonging to the various economic groups needing palliative care? So again, there is no major diversification out here. Palliative care is needed uniformly across all income settings. Upper middle class income around 38%, lower middle class around 29%, high income 24%, and low income about 9%. This is the distribution as per 2020 Global Atlas of Palliative Care. So therefore, palliative care need is uniform across income settings. And what are the gaps in palliative care in our country? If you look at the ranking, which Dr. Parija also mentioned, palliative care provision ranking worldwide. In 2010, India ranked 40th amongst 40 countries which were assessed. In 2015, we made a slight improvement to 67th position amongst the 80 countries which were assessed. In 2020, we are ranked 59th amongst the 80 countries are assessed. Not a rank to be very proud of. The fact remains that the quality of dying in India, the common perception is not a country to die in. We know that we are making steady progress, but we do have a long journey ahead to be counted amongst the best places where the palliative care is available to all those people who require advanced palliative care. Again, gaps in the palliative care provision. It's also seen that India is one of the costliest spaces to die in the world, because 63% of the population who require quality of the palliative care, the money is spent out of the pocket. This is the World Bank data of 2019. According to a Lancet report, 60 million families are becoming poorer due to health-related costs in India, and majority of these costs for the last few days of life. What I would like to emphasize here is access to good quality palliative care reduces the cost of end-of-life care. And therefore, I think it's an important aspect, and there needs to be long-term policies with regard to palliative care, long-term policies with regard to capacity building in terms of palliative care, more and more dissemination of information, making people aware of, even the healthcare fraternity, the importance of palliative care is often not taken too seriously. Therefore, the points which Dr. Parija made about integrating the concept of palliative care in undergraduate medical education, which is happening, though it should be at a much higher scale. And rarely ever, in some of the very select institutions, does the palliative care form a part of the curriculum in the postgraduate medical education. And very specifically, very few institutions in the country are able to improve or build capacity with regard to provision of manpower requirement regarding palliative care. Some more gaps in the palliative care provision. The point that Dr. Parija made is about the availability of opioid preparations for pain relief at the end of life. What is interesting to see, or rather distressing to see, is less than 4% of the people in India with malignancy who need opioids for pain relief have access to it. The gap is too wide. There is a need for us to really look at our availability of opioid preparations, pain relief, medications, and there is definitely a very big disparity between opioid availability and opioid access to the patient who actually need it. So there is for us points to ponder about. How do we make this gap narrower? How do we make available, oral opioids for pain relief to a larger segment of people who actually need it, especially people with cancers who are actually requesting pain relief, so that we make their we improve their quality of life, and they improve their terminal days to be pain-free. The other provisions is about some of the social factors which impact India. The surveys have shown that, in this particular study, 83% of the population in India prefer to breathe their last at their homes. On the contrary, majority of the patients spend their last few days in the intensive care unit. And what is more distressing is 15% of the population leave intensive care units against medical advice, perhaps not duly counseled, not duly supported, and therefore there is a lot of distress about these patients who move against medical advice to another institution or to their homes, and often leading to conflicts, often leading to litigations, often leading to dissatisfaction. Therefore, palliative care access avoids unnecessary medical interventions at the end of the life. And also, it brings in dignity in death for all those patients who are terminally ill. Once we realize that the end is nearer, it is important for us to make things better for that individual, not necessarily violating his dignity in terms of, say, doing a tracheostomy for breathing, an intubation for ventilatory support, and also for gastrostomy or jejunostomy for feeding, or putting in all kinds of interventional lines, IV lines and arterial lines and catheters in all this. This is, I personally feel, is a violation of the dignity in death. When we know that the end is near, we need to make it easier, we need to make it better, we need to make it less expensive to the patients. And more and more, it is the social and psychosocial support to the parents and a quality of counseling that needs to improve to the immediate family of the patients who's terminally ill, and also a level of involvement of the caregivers in providing the right kind of communication, in providing the right kind of counseling, in facilitating in the quality of palliative care while in the institution or outside of the institution, if the patient prefers, or rather if the patients and his relatives prefer to take the patients home for the last few days of his life. The other gap is what is alarming when compared to many other Western countries. It's access to independent hospice, especially for, this is a study which has been published by some of our people. Dr. Naveen Salams is the head of the Department of Palliative Medicine in KMC Manipal. This study shows the availability of various support services. This was published in BMJ Supportive and Palliative Care. Access to independent hospice is available only to 37 patients of the people who require palliative care. And in India, hospice attached to a cancer center is 0%. I think this is something which is very, very critical. And access to home care services is available to less than 34% of the patients who actually need it. So most of the hospices in India at present are standalone hospice. There's no cancer center or medical institute in India that has its own hospice. Of course, certain specific areas have been created within some of the institutions, some of the hospitals, but hospice as a concept is standalone. Much of it is privately held or run through NGOs, but none of the cancer centers or medical institutes in India have their own hospice. This is as per data in 2020. And also, what is more alarming and critical is no hospice in India is funded by the government. I think these are definitely points to ponder. So what have we done in palliative care development in Manipal? We have taken a very comprehensive look at the need and the level of availability of palliative care in the country. I'm very happy to see that Dr. Parija mentioned that in your own institution, the department has begun in the year 2016. A couple of years later, we started. And we are catering to both cancer and non-cancerous conditions. There are 4 consultants with specialist qualification in palliative medicine. We are the first institute in India, in South India, to start an MD in palliative medicine program. We are the first private medical college in India to start MD in palliative medicine program. And we are actively involved in research in palliative medicine, conducting research studies funded by NIH, NCI, and ICMR. Several educational, service development, and research collaborations are on with many institutions within our country and with institutions abroad like Singapore, UK, USA, and Australia. The department also conducts very regular orientation programs, skill development programs, and knowledge giving programs with regard to palliative medicine, and also giving the right kind of information to all stakeholders with regard to palliative care. And the Department of Palliative Medicine has 4 vertical clinical services. One is oncology palliative medicine. Second is an intensive care palliative medicine, pediatric palliative care medicine, and kidney supportive palliative care medicine. And some of the important initiatives that the Department of Palliative Medicine has taken with regard to development of the first ever handbook called Blue Maple, which gives a first procedural guidance document on limiting life-sustaining treatment, which was developed by Manipal in 2019, which later on has become part of some of the policies within the country. In 2018, Manipal was the key stakeholder in ICMR initiative on standardizing end-of-life care definitions. In 2000, Manipal also played a very pivotal role in drafting the end-of-life care section of the NABH accreditation manual. These are some of the important initiatives which have resulted in policy documentation with regard to palliative medicine and end-of-life care. And the department also enjoys 3 international accreditations for excellence in the 3 domains of practice of palliative care. One is by European Society of Medical Oncology. This accreditation is available from 2019 for excellence in integrated oncology, palliative care practice. There are only 5 cancer centers in India that have this recognition. The department also enjoys a recognition by International Collaborative European Union for accreditation beyond 2022 for excellence in end-of-life care policy, practice, and advocacy. This is first institution in India to have this recognition. And early this year, we also got the accreditation and recognition as a center of excellence in supportive care in cancer by Multinational Association by Supportive Care in Cancer. This is first in Asia to have this recognition. These are some of the important accreditations and recognition that the Department of Palliative Medicine has been having in its quest for excellence and in its effort to make palliative care available, affordable, and to make things better for people who actually require palliative care. And the new initiative that there is an approval already, that the new hospice is being built. It will have about 100 beds. This plan has already been approved. The work has already started. We expect to have this new 100-bedded new hospice specifically catering to the palliative care being established at Manipal, little away from our main campus, less than about 10 minutes drive. This comprehensive integrated facility, which will have capacity of 100 beds with integrated medical, paramedical support and other facilities. And I'm sure this is going to be one of the landmark events when it happens, that we will be the first medical college hospital in the country to have an integrated hospice, which is catering to such a large capacity as 100 patient intake capacity. So in brief, this is what I had to speak on. And let me thank Professor Parija and his team for making this happen and allowing me to be part of this very important meeting. I think all topics, subjects which Dr. Parija and his team selects are always thought-provoking. And it's always my pleasure to be part of such events as we go forward. Thank you all very much, and Jai Hind.
Thank you very much, sir. And KMC Manipal indeed has been the work which KMCH Manipal has been doing is very, very impressive. And you have brilliantly pointed out the need of the hour to integrate palliative care in the medical ethos of our country. And I would go just one step ahead as in saying that palliative care needs to be incorporated in the government health funding also, in all these CM scheme fundings and Ayushman Bharat Yojana and other things, so that the cost from out of the pocket expenses for the clients, it reduces to a considerable extent. Thank you very much, sir. And we move on to the next speaker, who is Professor R.S. Neelakandan, the Honorable Vice Chancellor, Meenakshi Academy of Higher Education and Research, deemed to be University Chennai. Professor Neelakandan has excused himself as he wanted to carry on with an important meeting with the health minister. And he has actually sent his the gist of his topic, which is research and advances in palliative care, which I will be speaking about. So research in the palliative medicine program seeks to identify and fix common symptoms by developing new methods of patient reported outcomes, develop new ways to fix common and uncommon symptoms such as dyspnea, malignant ascites, and chronic pain, develop better ways to communicate goals of care and life planning with compassion and maintained hope, increase knowledge about the impact of palliative care alongside the usual care, expand palliative care to populations not previously studied, such as phase 1 patients. Now, the research is concentrated in areas of integration of palliative care into patient care. Currently, there are research projects for patients with pancreatic cancers, patients on new and investigational phase 1 drugs, and patients in the emergency department. Plans for future research include concurrent palliative care for those with lung cancer, liver cancer, and getting transarterial chemoembolization for liver cancers. Research also is dwelling in the quality improvement in the care of patients eligible for palliative care, specifically patients undergoing rehabilitation and those with drainage tubes or hematologic malignancies, among others. Research is also focused on communication about serious illness with intentional discussions about the cost of care, creation of a question prompt list for the use of oncology offices, creation of a patient-centered app to stimulate discussion of important matters, etc. Many institutes are also involved in creation of videos and other tools to promote more and meaningful instructive conversations about surgical procedures related to cancer treatment, such as Whipple procedures and other serious illnesses and conditions. Now, new methods of pain control also are being investigated using the patient-specific neurocutaneous stimulations, etc., with MC5A CalMare scrambler therapy. Recent advances in palliative care, if we have to speak about, will involve a better management of chronic cancer pain through thoughtful use of common analgesics, including opioids, as Dr. Venkatesh Gupta sir has already pointed out. Recognition that the neuropathic pain requires additional treatment with anticonvulsants or tricyclic antidepressants. Improved management of other symptoms, gastrointestinal symptoms, dyspnea, confusional states, and depression, etc. Then increasing the use of advanced care planning to preserve the patient autonomy and choice around the time of his death, when the capacity to make the decisions may be impaired. Improved understanding of the role of artificial feeding and hydration of dying people, especially those with neurological impairments. General consensus on acceptability of withholding or withdrawing life-sustaining supports of the rule of the double effect, which permits the use of opioids and sedatives to relieve suffering from even if the death may ensue. To achieve our ambitious goals now, we must achieve interdisciplinary work, build robust theoretical models or methods, understand causal mechanisms, conduct the prospective longitudinal investigations of diverse patient populations, conditions, context, and settings, implement the methodical rigor and diversity of study designs and approaches, and develop and test interdisciplinary, culturally sensitive care models and interventions, which has been rightly pointed out by Dr. Gupta sir and Dr. Parija sir very well in their presentations. Thank you very much for attending this webinar, and happy to have you here. Any questions from the audience? We will get in touch with you. We'll try to answer them. Thank you very much. Have a good evening.